Patients here.
Oh boy, got some blood going.
Yeah, there's blood.
Oh, he's wearing it too.
Welcome to the bed. When you get over to the bed, we'll go ahead and give you the story. This is all going to happen super fast. Welcome to the emergency room.
70-year-old female, single driver vehicle, appears that she went off-road into a ditch, rolled over her car into a tree, caved in, the top of the vehicle was caved in, so she was hanging out partially from the window. She's been in application for
your left hand.
45 minutes of CPR. We can stop CPR with 600, 600, 600.
Welcome back to the deep dive. Today we are wading into what I think it's fair to call the deep end of the nursing board.
Oh, absolutely, the deep end.
We're standing at the bedside of a patient who weighs maybe 7 pounds, has a heart the size of a walnut, and inside that walnut, the plumbing is, well, it's trying to compromise their ability to breathe and grow. We are talking about pediatric cardiac nursing.
It is the ultimate high-stakes environment. I mean, I have seen seasoned nurses, people who can handle a chaotic ER on a Saturday night, just freeze up when they have to deal with a congenital heart defect.
And why is that? What's the core of that fear?
Because the margin for error with a neonate it's effectively zero. And unlike an adult, who can grab their chest and say, hey, I'm in pain, a baby tells you nothing.
Right.
They just stop eating.
Right.
Or they sweat. Or they turn a color that human beings simply are not supposed to be.
Exactly. And I've got to be honest, looking at the stack of materials we have for this deep dive, I mean, textbook chapters on congenital defects, specific clinical guides for beta blockers, diagrams of fetal circulation that look like subway maps drawn by someone in a fever dream. It is intimidating.
It really is.
It's a soup of acronyms: VSD, ASD, PDA, TGA, HLHS. It feels like you need a degree in fluid dynamics just to read the chart.
It absolutely feels that way. But that is exactly why we're here. We are not just going to read the slides to you. We're going to decode the logic behind it all.
A survival guide.
We're calling this the Pediatric Cardiac Power Hour. But yeah, it's a survival guide. We are going to apply the Pareto principle, the 80-20 rule.
I love the 80-20 rule. So for the listener who's maybe staring at a textbook right now and panicking, break that down for us.
It's simple, really. In pediatric cardiac nursing, about 20% of the concepts, and specifically we're talking about the core patterns of blood flow and pressure gradients, that 20% will answer 80% of your exam questions.
Okay, that's good for the test.
But more importantly, it will help you catch 80% of the life-threatening issues at the bedside. If you understand the physics of why blood moves the way it does, you don't have to memorize a list of 20 symptoms for 20 different defects.
You can figure it out.
You can derive them. You can predict them.
That is the promise we are making today. We are going to give you that 20%. We're drawing heavily from Chapter 19 on alterations in perfusion and a very specific clinical guide on propranolol.
Yes, that one's crucial.
We're going to map out the transition from the womb to the room, the specific defects that flood the lungs versus the ones that starve them, and the acquired diseases that can strike later, like Kawasaki.
And we absolutely cannot forget the pharmacology. That clinical guide on propranolol is it's full of red flags. One wrong instruction to a parent about how to handle that bottle.
And what could happen?
You could crash a baby's blood sugar. You could cause a seizure. It is that specific.
So let's start with that big picture. Before we get into the weeds of, ventricles and valves, what is the fundamental shift we absolutely need to understand?
The fundamental shift is the transition from fetal circulation to neonatal circulation. Everything, and I mean everything, hinges on that first breath.
Okay.
You have to remember, in the womb, the fetus it's underwater. The lungs are effectively solid organ tissue because they're filled with fluid. They are a high-pressure zone. You can't pump blood through them easily.
And you don't need to, right? Because the placenta is doing all the breathing.
Correct. The placenta is the lung, it's the kidney, it's the gut, it does everything. So the fetal heart is designed with what I like to call bypass roads.
Bypass roads, I like that.
It knows lungs are closed for business, so it uses 2 specific shortcuts to route blood around them.
And let's name these shortcuts, because I'm guessing if they don't close later, they become the defects we have to treat.
That's exactly it. The first is the foramen ovale.
Foramen ovale.
This is a literal hole, or more like a flap, between the right atrium and the left atrium. Blood comes into the right side, it hits that high resistance from the fluid-filled lungs, and it basically says no thanks.
It's not going that way.
And it just slips through this side door, the foramen ovale, directly into the left atrium to get pumped out to the body.
Efficient. Very efficient. And the second one?
The second one is the ductus arteriosus. This connects a pulmonary artery directly to the aorta.
Another bypass?
Exactly. So if any blood does sneak past the first door and gets into the pulmonary artery, instead of fighting its way into the lungs, it takes this little off-ramp straight into the aorta.
Okay, so just to get this straight in my head, in a fetus, right to left, flow bypassing the lungs, that's normal. It's actually necessary.
It's essential for survival in the womb, but then birth happens.
It's a big moment.
The cord is clamped, the placenta is gone. Suddenly, systemic resistance, the pressure of the body skyrockets.
Yeah.
And the baby takes that first massive, life-changing breath.
And that one breath changes all the physics.
Completely. The lungs inflate with air. The fluid is pushed out. All of a sudden, the lungs go from being a high-pressure brick to a low-pressure sponge.
Wow.
Blood just rushes into the lungs, and that massive rush of oxygenated blood returns to the left atrium, which increases the pressure there.
And that pressure does what?
It slams the foramen ovale shut, like a trapdoor.
And the ductus arteriosus, that other bypass.
The rise in oxygen levels from breathing signals the smooth muscle in that vessel to clamp down. It constricts and closes. So within a few days, those bypass roads should be gone.
And you're left with a normal circuit.
You are now running on a series circuit. Lungs, then body. Lungs, then body. Over and over.
But when they don't close, or if, the walls weren't built right in the first place, that's where we get congenital heart defects.
Exactly. Congenital means born with it. And this brings us right to our master 80-20 map. Instead of memorizing 50 different defects, we look for patterns.
I love patterns. What's pattern number 1?
Pattern number 1 is the hemodynamic shunt.
Blood going the wrong way.
Just blood going the wrong way. And this is all about pressure gradients, right?
High to low, always.
Always. Blood flows like water downhill from high pressure to low pressure. The left side of the heart is the powerhouse. It pumps to the whole body, so it's high pressure. The right side is the low pressure pump, just for the lungs.
So pattern 1A, I'm guessing, is when blood flows from left to right?
Correct. High pressure on the left leaks into the low pressure on the right. And where does the right side go?
To the lungs.
So this floods the lungs. These are your pink kids with wet lungs.
In kids with wet lungs, okay.
Yeah.
And 1B.
That's the reverse. If the right side is blocked for some reason, the pressure builds up there and it forces unoxygenated blue blood over to the left side and out to the body. These are your blue kids.
Okay, so right there, that's a huge clue. If I'm taking an exam and the question describes a cyanotic or, a blue baby, I immediately know I'm looking for a defect that pushes blood right to left.
Precisely. You have just eliminated half the possible answer choices.
That is the kind of shortcut we need. That's the 80-20 in action. What about pattern number 2?
Pattern number 2 is the failing heart, or heart failure, HF. But here is the critical, can't-miss takeaway. Heart failure in a baby does not look like heart failure in an adult.
Okay, how so?
An adult clutches their chest. An adult says, I have an elephant on my chest. A baby can't do that.
So what do they do instead?
They stop growing. The absolute classic assessment cue is sweating during feeds.
Sweating during feeds. That is such a specific and kind of strange image.
It is. But imagine you had to run a marathon while trying to drink a milkshake through a coffee stirrer.
Impossible.
That is what breastfeeding feels like for a baby in heart failure. Their metabolic rate is just through the roof. So pattern 2 is failure to thrive, plus respiratory distress, plus that key feeding difficulty.
You got it. And pattern 3, what's that one?
Pattern 3 is the inflammatory storm. This is the acquired stuff. This isn't plumbing you're born with. This is something that happens later. Think Kawasaki and rheumatic fever. The danger here isn't usually the initial plumbing. It's the immune system attacking the heart structures, like the valves or the coronary arteries.
And the final pattern?
Pattern 4.
Pharmacology safety. Specifically, the can't-miss rules for beta blockers, like propranolol. Knowing when to hold the med is just as important, if not more important, than knowing when to give it.
All right, let's go deeper. Let's do the system-by-system breakdown. We've covered the transition. Now let's talk vital signs. I feel like this is a massive trap for students who are used to working with adults.
It is a huge trap. If you walk into a room and you see a heart rate of 100 in an adult, you're concerned. You're watching them.
Sure.
In a 1-month-old infant, a heart rate of 100 is, well, it's actually on the low end of normal.
Really? 100 is low?
Yes. An infant's heart rate can range from 90 all the way up to 160 beats per minute. And if they're crying, it can go even higher. A resting heart rate of 140 BPM is perfectly, totally normal.
And blood pressure, I assume it's the opposite, much lower, maybe around 80/55. As the child ages, the heart rate gradually goes down, the blood pressure gradually goes up. By the time they're an adolescent, they start to reach those adult norms we're all used to.
Okay, so exam tip right there. Do not apply adult vital sign standards to a neonate.
You will either call a code on a perfectly healthy baby
Or worse.
or ignore a crashing one.
Okay, let's dive into that first category of defects, the pink defects, the ones with increased pulmonary blood flow.
These are our left-to-right shunts. So the main players you'll see are Atrial Septal Defect, or ASD, Ventricular Septal Defect, VSD, Patent Ductus Arteriosus, PDA, and then a more complex one, Atrioventricular Canal Defect.
Let's group them together. So ASD and VSD are basically holes in the walls, right? ASD in the top chambers, the atria, and VSD in the bottom, the ventricles.
Correct, or just a hole in the septum.
And PDA is that leftover fetal vessel staying open. Why do we call them pink? What's the logic there?
It's because oxygenated blood is recirculating. The blood has already been to the lungs, it's red, it's full of oxygen. It went to the left side of the heart, but instead of going out to the toes where it's needed,
It leaks back.
it leaks back through the hole to the right side and goes to the lungs again. So the body is still getting oxygenated blood. The baby isn't blue, they are pink.
But the lungs are getting double the volume, just overwhelmed with blood.
Exactly. It's a traffic jam in the lungs. This leads directly to pulmonary congestion. Wet lungs. If you put a stethoscope on their chest, you're going to hear crackles.
And this brings us right back to that heart failure pattern you mentioned.
It's a direct line. The heart has to pump so much harder to manage this chaotic flow. So the right side of the heart can enlarge, it gets overworked, and the baby's metabolic demand just skyrockets.
Let's talk about the PDA specifically, the Patent Ductus Arteriosus. This one seems to have a very specific treatment that exams just love to ask about.
They do. A PDA is that leftover connection between the aorta and the pulmonary artery.
Oh.
And the classic keyword you need to listen for is a murmur that sounds like a washing machine. A continuous machine-like murmur.
Washing machine murmur. Okay, got it. And how do we fix this one?
Well, surgically you can ligate it, you can tie it off. But before we do that, if it's supposed to close and it hasn't, we can try to force it closed with medication. And we use indomethacin, or IV ibuprofen.
Wait, ibuprofen? You mean like Advil?
Essentially, yes.
Yeah.
They are both NSAIDs, non-steroidal anti-inflammatory drugs, and NSAIDs inhibit prostaglandins.
And what do prostaglandins do?
Prostaglandins are the chemical that keeps the ductus open in the womb. That's their job. So if you block the prostaglandins,
You encourage the hole to close.
you take away the signal that's keeping it open.
So indomethacin closes the hole. I'm repeating that out loud because I have a feeling that later on things are going to get confusing.
Please do.
Yeah.
Indomethacin equals a closed PDA.
Now, let's connect this to the developmental impact. This is the need to know for nursing care, right? We have a baby who is breathing fast to chipney, and they're burning calories like crazy just to keep their heart beating. What does that do to their growth?
It stops it. This is the definition of failure to thrive. These babies, they just fall right off their growth curve.
So as the nurse, what's the priority intervention? Do we just feed them more?
You can't.
Yeah.
You have to completely rethink feeding. You can't just let them breastfeed for 45 minutes straight. They will burn more calories eating than they actually get from the milk.
So what's the strategy?
Small, frequent feeds. We use high-calorie formula. We'll even fortify breast milk, bumping it up to 24 or even 30 calories per ounce instead of the standard 20. And we might even need to use a gavage feed.
So putting down an NG tube.
An NG tube, yes.
Yeah.
So they can get the nutrition without the work of sucking. It lets them rest.
Rest becomes a medical intervention here.
Absolutely. Clustering your care is essential. Don't go in every 10 minutes to poke and prod them. Go in, do the vitals, change the diaper, give the medication, and then let them sleep. They need that energy to grow heart muscle.
Okay, let's flip the script. Let's talk about the blue defects, the ones with decreased pulmonary blood flow.
This is our pattern 1B, the right to left shunt. Something is blocking the blood from getting to the lungs in the first place.
An obstruction.
A major obstruction. So the unoxygenated blue blood gets frustrated. It can't go forward, so it pushes through a hole, usually a VSD, and goes out to the body without ever picking up oxygen.
Hence, the baby is blue. Cyanotic.
Right. And the big bad wolf in this category is tetralogy of Fallot.
Tetralogy. That means 4. So we need to memorize these 4 specific defects.
You absolutely do.
Okay, walk us through them. What's number 1?
Number 1 is pulmonic stenosis. The valve leading to the lungs is tight and narrow. This is the main problem. It's the source of the obstruction.
Okay, a tight valve. What's number 2?
Number 2 is a consequence of number 1, right ventricular hypertrophy. The muscle of the right ventricle gets really thick and beefy from trying to push blood against that tight stenotic valve.
Makes sense.
Number 3 is a VSD, a ventricular septal defect, a hole between the bottom 2 chambers.
And the last one, number 4.
Number 4 is the overriding aorta. The aorta, instead of sitting neatly over the left ventricle, is shifted over so it sits right on top of that VSD.
So it's sucking up blood from both sides.
Exactly. It's getting a mix of red blood from the left and blue blood from the right.
That sounds like a recipe for disaster.
It is. And it leads to the single most famous exam scenario in all of pediatric cardiac nursing, the TET spell.
Also known as a hypercyanotic spell.
Correct.
Paint the picture for us. You're the nurse. What happens?
Usually it's triggered by something that increases oxygen demand. So the infant is crying or feeding or even just having a bowel movement. Suddenly that tight pulmonary valve spasms and shuts down even more.
So even less blood gets to the lungs.
Almost no blood goes to the lungs. The baby turns profoundly blue. They get limp. They might even lose consciousness. It is absolutely terrifying for parents to witness.
And as the nurse, you walk into that room. What is your immediate first line do it now action?
Need a chest position.
Okay, why? Why does shoving a baby's knees into their chest help their heart? It seems so counterintuitive.
It's pure physics. By kinking the femoral arteries in their legs, which is essentially what you're doing, you dramatically increase the systemic vascular resistance, or SVR.
So you're making it harder for blood to go down to the legs.
Right, and that back pressure, that high pressure in the body, forces the blood to choose the other path, the path of least resistance, which is now back into the pulmonary artery into the lungs. It reverses the shunt temporarily.
That is brilliant. It's like mechanical shunting with your hands.
It works, and what's amazing is, for an older child with unrepaired tetralogy of Fallot, you'll see them do this instinctively.
What do you mean?
They'll be running around on the playground, they'll get winded, and they will suddenly just squat down in the middle of playing.
They're giving themselves the knee to chest position.
They are self-treating a mild TET spell.
Wow. So squatting to breathe? That's a major developmental red flag if you see it in a toddler.
It is a huge one. If a parent ever tells you, oh, he always squats when he plays tag, that kid needs an echocardiogram stat.
Aside from the squat, what else do we do for a TET spell?
Okay, so after knee to chest, you want to apply 100% oxygen, usually by blow-by, so you don't agitate them more. You want to calm the child. Morphine can help relax that spasm and reduce the agitation. And then IV fluids. But knee to chest is always step 1.
Okay, another one of these blue defects is tricuspid atresia.
Yes, and the key word here is atresia. It means missing or completely closed off.
So the tricuspid valve.
The valve between the right atrium and the right ventricle. It just isn't there. It's a solid wall of tissue.
So no blood can get from the right atrium to the right ventricle.
Nope. It's a dead end. The only way this baby survives is if there are other holes, an ASD or a VSD, to let that blood escape and mix somewhere else.
And this brings us to a really important pharmacology twist.
Yes. In tricuspid atresia, or really any severe obstruction to lung flow, the blood flow to the lungs might be completely dependent on that ductus arteriosus we talked about earlier.
The one that's supposed to close? The PDA.
But the very same. But in this case, if it closes, the baby dies. Because that backflow from the aorta through the PDA and into the pulmonary artery might be the only blood the lungs are getting.
So we have to keep it open.
We must keep it open.
Ah.
So what do we give?
The opposite of what we gave before.
Exactly. We give prostaglandins, specifically a continuous IV drip of prostaglandin E1.
And this is the prostaglandin paradox. I want to say this clearly.
Go for it.
For a simple PDA where we want it closed, we give indomethacin, which is an anti-I of prostaglandin.
Correct.
But for something like tricuspid atresia, where we need it to stay open for survival, we give prostaglandins to keep it open.
You have to know the defect to know the drug. If you give indomethacin to a baby with tricuspid atresia, you are effectively cutting off their only source of oxygenated blood.
That is a massive can't-miss safety item. Always, always check the diagnosis before you even think about touching the indomethacin.
100%.
Okay, let's shift gears. Let's move to the obstructive disorders. The pipes are pinched.
Coarctation of the aorta is the big one here. Coarctation is just a fancy word for narrowing. It usually happens in the aortic arch right after the arteries branch off to the head and the arms, but before the arteries go down to the legs and the rest of the body.
So if you imagine a kink in a garden hose.
It's the perfect analogy. Upstream of the kink, so the head and the arms, the pressure is super high. Downstream of the kink, The legs and the kidneys, the pressure is just a trickle.
And this leads to a very, very specific assessment finding, doesn't it?
The hallmark finding, a disparity in pulses and blood pressure between the upper and lower extremities. You check the BP in the right arm, and it's high. You feel the brachial or radial pulses, and they're bounding.
And then you check the legs.
You check the BP in the leg, and it's low. And you try to feel for femoral pulses, and they're weak or maybe even absent.
And normal physiology says that leg BP should be a little bit higher than arm BP, right?
Correct. So if you find that the leg pressure is lower than the arm pressure, you have just diagnosed coarctation of the aorta.
And what's the long-term risk here?
Well, you've got two problems. Stroke for the brain because of that severe hypertension in the upper body, and poor perfusion to the gut and the kidneys downstream.
Developmentally, how might this present in a slightly older child who's, walking and talking?
These kids might complain of leg pain or cramping with exercise, that's claudication. Or they might have frequent headaches and nosebleeds from the high blood pressure in their head.
Nosebleeds and leg pain, taken separately, those sound like typical growing pains. But if you put them together...
Cardiac red flag.
Okay, now for the really complex ones, the mixed defects. Let's start with transition of the great arteries, or TGA.
This is a plumbing nightmare. The aorta and the pulmonary artery are just swapped. They're hooked up to the wrong ventricles.
What does that mean for blood flow?
It means the right ventricle pumps blue, unoxygenated blood into the aorta, which goes out to the body and comes back blue. And the left ventricle pumps red, oxygenated blood into the pulmonary artery, which goes to the lungs and comes back red.
You've got two completely separate parallel circles that never touch.
Exactly. The body gets zero oxygen. This is incompatible with life unless
there's a hole.
Right. There has to be a place for the blood to mix. We need a PDA or an ASD or a VSD. And again, this is a prostaglandins and now emergency. Keep that ductus open at all costs until surgery can switch the vessels back to where they belong.
And what about hypoplastic left heart syndrome, HLHS?
Hypoplastic just means underdeveloped. So in HLHS, the entire left ventricle, the main pump for the body, is tiny, non-functional, and undeveloped. It can't pump blood to the body.
This sounds incredibly severe.
It is one of the most severe. These babies typically require a series of 3 palliative surgeries, the Norwood, the Glenn, and the Fontan, starting in the very first week of life, just to survive.
The developmental impact here must be absolutely massive.
It is. These children can spend months of their first few years in the hospital. They have sternal precautions after surgery, meaning you can't lift them up under the arms. So their gross motor milestones, like rolling over or crawling, are often delayed because they're tethered to machines or recovering from open heart surgery.
And feeding has to be a challenge.
A huge challenge. Many of these babies develop oral aversions. Think about it. They've been intubated, suctioned constantly, had NG tubes down their nose. They start to associate anything near their mouth with pain or discomfort.
So even after the heart is fixed, you're left with a major behavioral feeding issue.
Exactly. You might be dealing with a toddler who simply refuses to eat by mouth.
That brings us to the soft skills part of the outline, the psychosocial aspect. But honestly, calling it soft feels wrong. It's hard.
It's the hardest part. You, the surgeon, you fix the hole. But you send home a family that is completely terrified.
So post-op teaching is critical. What's one of the first things parents ask?
Can I pick him up? Can I hold my baby?
And the answer
is yes, please do. But we have to teach them how. You scoop them, support the head and the bottom. You just don't lift them under the arms because of the stress on that fresh sternal incision.
Why is that holding so important?
Because bonding is priority number 1. If the baby cries, their heart rate goes up, their blood pressure goes up, the workload on their heart goes up. A comforted baby is a hemodynamically stable baby.
I love that. A comforted baby is a hemodynamically stable baby. Everyone listening, write that down.
Also, simple things. Incision care. Keep it clean, keep it dry. No lotions, no powders. And teaching them the signs of infection, redness, drainage, fever.
Okay, let's pivot. We've covered the born with it, the congenital defects. Now let's talk about the acquired, that inflammatory storm you mentioned. Pattern number 3. Let's start with Kawasaki disease.
This is a weird one. We still don't know exactly what causes it. It's idiopathic, but it's an acute systemic vasculitis.
So inflammation of all the blood vessels.
Exactly, all throughout the body.
And who gets it? What's the typical age group?
It's almost always toddlers and preschoolers, usually children under 5 years old.
And what does it look like? How does it present?
It comes in phases. The acute phase is the most dramatic. The hallmark sign is a high fever, over 102, that is unresponsive to Tylenol or Motrin. and it lasts for 5 or more days. That's the key.
A persistent high fever. Plus what else?
Plus the cream symptoms. It's a mnemonic.
Okay, break down cream for us.
C is for conjunctivitis red eyes, but with no drainage or pus. R is for rash, usually all over the trunk. E is for edema swelling of the hands and feet, and erythema bright red palms and soles. A is for adenopathy swollen lymph nodes, usually just one in the neck. And M is for mucosal changes.
And that's where we get that classic exam description.
The strawberry tongue and cracked red bleeding lips.
And I've heard about peeling skin, too.
Yes, that comes a little later, in the subacute phase. The skin on their fingertips and toes will start to peel off in sheets.
Why is this so dangerous? I mean, it sounds miserable, like a really bad flu, but why is it a cardiac emergency?
The danger is the heart. The inflammation has a special affinity for the coronary arteries. It can cause aneurysms, weak, ballooning spots in the arteries, which can then lead to blood clots and heart attacks in a 5-year-old.
A heart attack in a child? That's terrifying. So how do we treat it? This brings us to a major pharmacology exception.
We treat it with 2 main things. First, a big dose of IV intravenous immunoglobulin to calm the whole immune system down, and high-dose aspirin.
And there should be a siren going off in your head right now. Aspirin in kids.
Normally, we never give aspirin to children because of the risk of Ray's syndrome, which causes massive liver and brain swelling, especially after a viral illness like the flu or chickenpox.
But this is the exception.
Kawasaki is the one time the benefit preventing coronary artery clots outweighs the risk. We need that antiplatelet effect from the aspirin.
So an exam writer's favorite question would be, which of these children requires a prescription for aspirin?
And the answer is always the child with Kawasaki disease. But you still have to teach the parents to be vigilant, to watch for signs of Ray's, and to avoid other viral illnesses because the risk, while small, is still there.
Next up in the acquired category, rheumatic fever.
This is another autoimmune reaction, but this time we know the trigger. It's group A strep.
So an untreated case of strep throat.
Exactly. About 2 to 4 weeks after a sore throat that wasn't fully treated, the child's body develops antibodies that are supposed to fight the strep, but they mistakenly attack their own heart valves.
And which valve is most commonly affected?
Usually the mitral valve, but the antibodies can also attack the joints in the brain.
How do we diagnose it? It sounds like it could be vague.
We use something called the modified Jones criteria. You need evidence of a recent strep infection, like a positive titer, plus either 2 major symptoms or 1 major and 2 minor symptoms.
What are the major symptoms?
The big ones are carditis, which is inflammation of the heart. Polyarthritis, which is a migrating joint pain. It'll be in the knee one day, the elbow the next. Subcutaneous nodules, a specific rash called erythema marginatum, and chorea.
The chorea, that's St. Vitus dance, right? The jerky movement.
Yes. Sudden, aimless, jerky movements of the arms and legs. It can be really scary for parents to see.
Does it go away?
It does resolve, but it's very distressing while it's happening.
Yeah.
But the real priority here is prevention.
Treat the strep throat.
Just treat the strep throat.
Right.
If a kid has a sore throat and a fever, get a culture. If it's positive, make sure they finish the entire course of antibiotics.
And if they do get rheumatic fever, what's the long-term management?
Long-term antibiotics, sometimes for years or even into adulthood, to prevent a recurrence and to prevent further damage to the heart valves.
Okay, one more acquired condition, infective endocarditis.
This is basically bacteria growing on the valves or the lining of the heart. It often happens in kids who already have a congenital heart defect or who have prosthetic valves or central lines.
What are some of the weird classic signs for this one?
The classic ones are osselar nodules, which are painful, tender bumps on the finger pads. I remember it as O for ouch.
Oh, for ouch. Good one.
And then there are Janeway lesions, which are flat, painless red spots on the palms of the hands or the soles of the feet. And you might also see splinter hemorrhages under the fingernails.
And what's the key to prevention here?
Prophylactic antibiotics before dental procedures. If you have a high-risk kid, one with a prosthetic valve or a history of endocarditis, they need a dose of amoxicillin before the dentist even cleans their teeth.
Because the bacteria from the mouth.
Love to travel to the heart and set up shop on damaged tissue.
Okay, we are heading into the final stretch. Section C, the pharmacology deep dive. We've talked aspirin, indomethacin, prostaglandins. Now let's talk about a daily driver, propranolol.
Propranolol. It's a beta blocker, a class 2 antiarrhythmic.
And the key descriptor here is non-selective. What does that mean for us clinically?
It means it blocks more than one type of beta receptor. It blocks beta-1 receptors, which are primarily in the heart, and it also blocks beta-2 receptors, which are primarily in the lungs.
So what's the effect?
Blocking beta-1 is what we want. It slows the heart rate and lowers the blood pressure. Good. Blocking beta-2, however, causes bronchoconstriction. Bad.
So high caution in any child with a history of asthma.
Extremely high caution. It can trigger a full-blown asthma attack.
Now, looking at our clinical guide here, propranolol is used for arrhythmias, sure, but also for something pretty surprising, infantile hemangiomas.
Yes, those bright red raised strawberry birthmarks. Propranolol works wonders to shrink them. The brand name for this formulation is often hemangiol.
And there are some very, very specific administration rules for hemangiol in infants. Let's run through the need-to-know safety check.
Okay, rule number 1, feedings. You absolutely must give it during or immediately after a feeding, never on an empty stomach.
Okay, why is that so critical?
Because beta blockers can mask the signs and symptoms of hypoglycemia, low blood sugar. Normally, when your blood sugar drops, your body releases adrenaline. You get shaky, jittery, your heart races, tachycardia. Beta blockers stop all of that. They stop the jitters and they stop the tachycardia. So the baby could be dangerously hypoglycemic and you would have no idea until they have a seizure.
That is a critical life-saving teaching point for parents. No food equals monlolly.
Absolutely. Which leads to rule number 2, the vomiting rule. If the child is vomiting or just not eating well, hold of the dose. Call the provider.
Got it. What's rule number 3?
Rule number 3 is the shake rule. Do not shake the hemangiol bottle.
But why not? Almost every liquid suspension tells you to shake well.
Because this specific one creates a lot of bubbles and foam. If you draw up a syringe full of foam, you're not getting an accurate amount of medication. You're almost certainly going to underdose the child, so you just invert the bottle gently a few times.
And what about the black box warning?
Abrupt discontinuation. You cannot just stop propranolol cold turkey. It can cause a severe rebound effect, rebound hypertension, tachycardia, or in adults, even a heart attack. You must taper it slowly, usually over about 2 weeks.
So if a parent calls the clinic and says, oh, we ran out 3 days ago, that is an urgent situation.
That is an emergency. They need to get a refill immediately.
Wow. We've covered a massive amount of ground. Let's try to synthesize some of this. I want to do a rapid fire compare and contrast. Ready?
Let's do it.
Congenital versus acquired.
Congenital is structural plumbing issues. You're born with it. The main problem is hemodynamics, so flow. Acquired is inflammatory or infectious, like Kawasaki or strep. It happens later. The main problem is damage to the vessels or the valves.
Okay. The prostaglandin paradox.
A simple PDA. We want to close it. We use indomethacin. Complex blue baby defects like TGA or tricuspid atresia, we might need to keep the PDA open for survival. We use prostaglandins.
Perfect. Fluid overload versus cyanosis.
Left to right shunt, like a VSD or ASD, gives you wet lungs and a pink baby. Your priority is monitoring for heart failure. Right to left shunt, like tetralogy of Fallot, gives you a blue baby. Your priority is monitoring for TET spells.
This really brings us to the so what for the listener. We've given them the 80-20, we've given them the patterns. What does it all mean at the bedside?
The so what is that pediatric cardiac nursing isn't just about the heart, it's about the whole child. A heart defect affects feeding, which affects growth, which affects brain development. It affects the parent's ability to bond with their sick infant.
So it's not just about the monitors.
When you walk into that room, don't just look at the monitor, look at the baby. Are they sweating when they eat? Are they squatting when they play? Are the parents terrified to touch them? Your interventions, knowing to put their knees to their chest, clustering their care to let them rest, teaching parents how to do high-calorie feeds, those are the things that save lives and save brains.
And just realizing that a normal heart rate for a 2-month-old is 130 helps you not panic and helps you focus on what actually matters.
Exactly. Know your norms so you can spot the real outliers.
We always like to end with a provocative thought, something for our listeners to chew on after we're done.
Okay, here's one. We've gotten really, really good at saving these kids. The survival rates for even the most complex congenital heart disease are higher than they have ever been. But that means we are creating a brand new patient population, the adult with congenital heart disease.
ACHD.
Right. And a heart that was fixed with a patch or a conduit at age 2 isn't a normal heart at age 40. They have scar tissue. They have a higher risk of rhythm issues. They have different hemodynamic pressures.
So what's the question?
The question is, how does lifelong acquired heart disease management, things like cholesterol, stress, diet, exercise, how does that change for someone who was born with a fundamental structural defect? We're entering an era where our pediatric cardiac patients are outliving their initial repairs. What does that long-term nursing care look like?
That is a fascinating frontier. The pediatric patient who is now 45 years old.
A whole new world of nursing.
All right, friends. Take a deep breath. Your heart rate should be returning to normal, unless you're an infant, in which case, try to stay around 140. Check the show notes for our 80-20 cheat sheet on all this. Keep those pressure gradients flowing.
And remember, never ever shake the propranolol.
I'll see you in the next